Can you see my screen?
No, doctor.
Okay, let's try again. Can you see my screen?
Yes.
Okay. So I think the last lecture we talked about these extra-oral appliance or extra-oral orthopedic appliance. So wherever you use the forces or encourage from outside the mouth, then call extra-oral. Of course, then we have the mild, moderate, and severe cases. So we can do growth modifications, camouflage treatment, surgical corrections. It depends on the severity of the malocclusions. So when it comes to skeletal discrepancy, then it's always the tricky one. So if the patient's still growing, then maybe you can do some growth modifications using the myofunctionals or extra-oral orthopedic appliances. But if you're just doing this mild discrepancy for adult patients, then when they're not growing, then maybe you can do the camouflage treatment only. So if they're still growing, maybe you can do growth modifications and camouflage later if necessary. Of course, a severe one, you go for surgical corrections. So what's the best? Then really, I already told you there's no best option for that. So it depends what the patient wants and how severe is the case. So communication is always a key for the successful treatment. So you have to see what's the patient complaint, what's the patient concern. Then before you come up with treatment options, then discuss the pros and cons. Then finally, we decide together with the patients. Then once it's decided, then you only execute the plan. Is that how it works for ortho? Okay, so I think we talked about this. Then extra-oral appliance, then the amount of force is usually higher, duration of force also a bit longer. Then direction of force, we have high pull, low pull. Then the age of patient must be growing patients. Then time of force application, timing of forces application also very important. So of course, extra-oral, generally we call it headgear. And of course, if you talk about headgear, then mainly we refer to something attached to the back of the skull. Then if you talk about face mask, it's something attached to the front of the face. Then chin cup, of course, they're attached to the chin. So headgear, I think this time we talk about this. Then I think we'll jump through these pictures, just a component. So very simple. Headgear have a component attached to the skull. Then you can attach to the parietal bone, occipital bone, or sometimes even the neck or the cervical area. Then we have something connect to intra-oral, which is a face bow. So face bow is just that two components also. The outer one is attached with the rubber band. The inner bow is attached to the molar bands or the molar buccal tube. So this is extra-oral attached to the skull. Then you have something intra-oral, which is a face bow. Then we need something to connect it. This is a rubber band or the spring will come in. Of course, face bow, this one we talk about it. There are two components, outer bow and inner bow. Okay, this one we talk about it also. You see the attachment can be elastic or sometimes it can be a spring. It doesn't matter. Wherever you have a pulling force, then they will work. Of course, with our directional pulling, then we have a high pull, then middle pull and low pull. So if the high pull, mainly the forces come from parietal bone, then the middle pull comes from occipital, then the cervical pull is a low pull. So it depends what you want to do. You want to intrude the incisor, intrude the maxilla, then go for high pull. We just want to distalize this molar, then go for middle pull. You want to extrude the maxilla or the molars, then you go for low pull. Depends what you want to do. So usually, if the patient have the vertical access, let's say the maxilla is too long, then you go for high pull because you want to intrude the maxilla or the molars. Then if the patient have the normal height, then maybe you go for horizontal pull. Then if the patient have the vertical height which is reduced, then maybe you go for low pull because you want to extrude the maxilla. Okay, so we have the neck cap. Sometimes we combine the head cap and the neck cap. So the neck cap mainly is for the safety purpose because a lot of time when the patient they are playing around with the peers or the friends, they like to pull the face bow on the front. So this neck strap, a long time they act as the safety features. So when they pull, then this one there's something stopping the face bow from coming out. So if you look carefully, so this face bowl, you see the dimensions or the width is really similar to the eye level, sorry, the eye width. So if this is not careful, if you pull it out, then the spring will pull it back, then it might injure the eye. So there's an incident in UK, then there's someone's got blind because this face bowl injury. So now they always come with the safety features. So like this one, without safety features, is already obsolete. So now most of the time we give it the neck strap also, just as a safety features. So when you pull this face bowl, then there's something stopping it. Of course, there are some other safety features also. Sometimes I call it snap mechanism. So when you pull the face bowl from the front, this one's a snap. So either you have a neck strap or you have a snap mechanism. Okay, similar. You see this one have a neck strap, then you have a high pull from the parietal bone. Then this one, the combinations, then you get a horizontal pull. So you can buy the similar one design, but you get the different direction of pulling. Depends on how you apply the force. So even though this is a high pull hip gear, if you neck the neck strap, then get horizontal pull. So it's a treatment effect because a lot of time for skeletal discrepancy, then we try to correct the skeletal. But unfortunately, how we correct the skeletal is by attaching a component to the teeth. So you can see this one, the headgear or whatever, face mask, they always have some component attached to the jaw through or via the teeth. Like this one, the face bowl attached to the teeth, then the elastic attached to the face bowl. Of course, the teeth connect with the jaw. So hopefully you apply the force to the teeth, then the jaw will move together. But unfortunately, if you apply the force to the teeth, it also causes the tooth movement also, whether you like it or not. Because we hope the skeletal effect will be more than the dental effect. But it still causes a dental effect because you're putting on the teeth. Okay. So skeletal effect, because you're putting high force to the teeth, then the teeth will transmit the force to all the maxilla or mandible. Then you'll compress the sutures, your headgear, then you'll compress the suture on the top. If the lower, then maybe you will restrict the growth of the mandible. So this one, the skeletal effect for the headgear, hopefully you can restrict the forward and downward growth of the maxilla. So we know that from the last or the previous lectures, then we know the maxilla is growing downward and forward. So to reverse it, then you need the force going upward and backward. That's simple. So you want to restrict something growth, you go opposite to it. So maxilla is going downward and forward. That's why the force for this headgear should be backward and upward. But this one doesn't cause any effect on the mandible because there's no component on the mandible. So mainly this headgear is still with the maxillary access. As the maxilla is too long, then too forward or pragmatic, then maybe use a headgear. But if the mandible is too short, then perhaps you can combine with the functional appliance. The functional appliance will advance the jaw forward, the lower jaw will come forward. So if a combination of both, then maybe you can use headgear plus the functional appliance, both. So dental effect, like I say, got this component attached to the teeth, it will cause some effect to the teeth also. So what's the effect? So that you are pulling the teeth backward and upward. Sometimes it causes some distalization of the maxillary molar or extrusion or intrusion. Depends on whether you're high pull or low pull or cervical pull. So like I say, high pull will cause intrusion, and horizontal pull or cervical pull, horizontal pull will cause the distalization of molar only. With the low pull, then mostly will cause extrusion of the molars. So as the uses headgear mainly just to restrain the maxillary growth because the force is backward and upward. Then of course they're maintaining this arch length. So arch length, because the arch length is already fixed when it comes to adult. So if you put this headgear, then hopefully you can maintain the arch length by pushing the teeth back or distalize the tooth. Then we have these molar distalizations. Then we have encouraged reinforcement also. Encouraged reinforcement is just that if you're having this severely porcine upper incisor, let's say 50 millimeters overjet, you don't want any bacteria coming forward. So even though you extract the premolar, you want the total distalization of the incisor. So you use this headgear to hold the molar in positions. Then you retract everything from the front to the back, rather than the bacteria coming forward. This is what we call the anchorage reinforcement. So during the braces or the fixed braces time, they may ask the patient to wear the headgear to hold the molar in position. So the molar is not coming forward, but the maxilla incisor will go backward all the way. So what's the limitations? So like I say, this one, the component is attached to the teeth. So whether you like it or not, it will cause some dental effect rather than a skeletal alone. So patient compliance, again, this one is a removable appliance. So patient can remove it themselves. So compliance is always difficult. When it comes to kids, then sometimes they are lazy, they are not disciplined. And if we get the effect you want, compared to adult, then adult usually a bit more disciplined. But unfortunately, adult is not growing. That's why we cannot use a headgear for adult. And a lot of time, the social impact is still there. Whether you like it or not, this one is considered ugly or not acceptable to the social society. So this one, if you ask the kid to wear it to school, then most of the time the friend will laugh. So this one, we should encourage them to do it after school. So when they come back from school, maybe after lunch, then maybe they start wearing it. Until the next morning you go to school. So we are talking about 12 to 16 hours, about that, more than half day. So if you wear less than half day, then usually the effect is not there. Then we need the adequate amount of mandibular growth to require the catch up. So let's say if your mandible is not growing, you just restrict the maxilla, then the overjet is still there. So this one, we restrict the maxilla, then hopefully the mandible will grow forward. If let's say this doesn't happen, then maybe we'll add in a functional appliance to advance the mandible. So it depends what is the problem. So when you see the overjet, massive overjet, then you look at the maxilla and mandible. See which one is the problem. If the maxilla is a problem, then maybe we deal with headgear. If the mandible is a problem, then maybe we go for functionals. Then if both also a problem, maybe they're both combination, then maybe we go for headgear plus a functional appliance. So reversible headgear, so this one mainly for the cut street patients. So you can see this one, we have two components as an ankle. So we have a forehead, then we have a chin. Then in the middle, we have the rubber band attached to the bar or the rod. So they have different designs in the UK. So different design doesn't matter. But the same thing is, they are trying to pull the maxilla forward. Then we restrict the growth of the mandible. So similar. Unfortunately, they cause some dental effect also, a little bit dental effect. Then hopefully we get more skeletal than the dental. Okay, so mainly this one is to pull the maxilla forward. Then we have to restrict the mandible. So the using for the growing patient with the constrema occlusion, with the prognathic mandible, which is long mandible, and retracted maxilla, which is a short maxilla. So you want to make the maxilla on the upper jaw longer, and the mandible trying to keep it shorter or restrict the growth. So this one is a forehead and the chin. We have two components as an ankle. Then in the middle, we have the bar, the connected. Then we have the rubber band attached from the maxilla, then to this bar. So this rubber band will pull the maxilla forward. Then this rubber band, usually patient have to change it every day. So if you're changing this every day, then it remains to maintain the strength of the rubber band. Then this one, if you wear it long enough, about 12 to 16 hours, then the force will be about 400 above. Then this one slowly will pull the maxilla forward. So duration, so the amount of force, I say it's going to be high. So if you're moving a teeth, then we're talking about maybe less than 100 grams. But you're moving a jaw, you need something double or triple or even 4 times or 5 times. So we're talking about 400 to 600 grams. So the directions must be the downward and forward, just to accelerate the growth of mandible, growth of maxilla. So we discussed before, the maxilla is growing the downward and forward direction. Downward and forward direction. So in order to simulate or mimic the growth of the maxilla, then the force, the directional force should be the downward and forward as well. So you want to restrict or you want to pull the maxilla back, then you reverse it. You should go upward and backward. But when the maxilla will grow more, then you go downward and forward. So the degree is about 15 to 20 degree downward pull from the occlusal plane. Then this one more than half day, the frequency of use. Then duration of treatment usually is about a year, 1 year. So in less than 1 year, usually you won't get a skeletal effect because the treatment time is too short. So the component, this one discussed before, they have extra-oral, intra-oral, they have something to connect it. So intra-oral, we usually have this RME, rapid maxillary expansion. Then this expander usually comes with a hook. So this hook will attach a rubber band to the rod or the bar. So this is an extra-oral component. We have something intra-oral, which is our RME with a hook. Then we have the rubber band to connect these two components, similar to the headgear. So this is a typical example for the RME. This one is the expander. So the expander, they have a screw in the middle. We call it mid-palatal screw. So whenever you turn this screw, they will expand the jaw. At the same time, you can have a hook attached to the teeth. Then this one is a very rigid connector. So when they pull this hook or you attach a rubber band, then they pull the teeth forward, then they'll connect the whole jaw together, and hopefully the whole jaw will come forward. So again, different design. Then the most popular one is a petit, which is a single rod in the middle. Because previously we have this double rod. Then we have the previous, the original design is by Hickam. Then this one, I think we don't use it anymore. Most of the time we use this too. Then why we moved to this one is because this one is more comfortable. Then patient when turning left and right, they're not disturbing. Then this one, you're turning left and right when they're sleeping, then it will disturb the bar. Of course, this one, I think now is cheaper because you see the component lesser. This one more expensive. So chin cap, very simple. So if your chin or the mandible is too long, then it's attached to something to it. And hopefully you can restrict the growth and mandible, similar to the headgear. So the headgear is attached to the maxilla, but the chin cup is only attached to the chin. So you just modify a little bit, maybe you can get both if you want to do it. So this chin cap mainly is same thing. It's extra-oral. Then we have a cap attached to the chin. Then of course you have a rubber band or spring attached these two components. But this one doesn't have the intra-oral component compared to the other two, the headgear and the face mask. Chin cup mainly extra-oral. But it still need the connector, which is a rubber band or the spring, connect these two components. Then we have a high pull, then we have a vertical pull and occipital pull. So this one, the make of the cap or the chin cap, then this one doesn't matter. It can be soft or it can be rigid. So this one is up to your personal preference. So the same tools applies. More than 12 hours or more than half day must be right. Then the force, usually we're talking about triple, 4 times, even 6 times, or compared to moving the teeth. So you just remember, if you cannot remember the forces, then for the teeth, then we are talking about maybe 50, 60, or 20, 30, less than 100. If we're talking about moving the jaw, then we need more than 100. So you remember this rule, less than 100, more than 100, or 3 times, 4 times, something like that. So the ideal patient for chin cup, then usually these patients have a longer lower jaw, then sometimes have the vertical access, and hopefully you can restrict the growth in mandible, or sometimes you can cause some intrusions, or you can shorten the jaw a little bit. So this one, we must have the normal positions or protrusive incisor. Because this one, whatever we do, then sometimes we retrocline the lower incisor. So if the lower incisor will be retroclined from the beginning, maybe that's not the case for this chin cup. So if the lower incisor retrocline a lot, or they lean back a lot, that means the dentures already compensate a lot for this case. So this patient mostly have a moderate to severe class 3 skeletal pattern. So remember, this skeletal or extra-oral orthopedic appliance, they usually deal with the mild to moderate skeletal discrepancy. When it comes to severe discrepancy, surgery might be the option. So this one conclusion, I think we'll skip that. So remember, whatever we do for these myofunctionals and extraoral appliances, then we hope to get skeletal rather than the tender effect. So skeletal, maybe you can modify a little bit, not to the great extent, but you reduce the severity of the malocclusion or the severity of the skeletal discrepancy. Then hopefully, they'll make the job easier. If you're not correct it fully, but they'll make the job easier, which patient can avoid or maybe can avoid the surgery. That's what we're hoping. But sometimes for the severe case, you still have to go for surgery, no matter what we do. Okay, so I hope that's clear for these extraoral appliances. So do you have any extra questions to ask me before we move on to the tutorial questions? Silent. I assume there's no questions. Can someone just say no questions?
No question, doctor.
Okay, so I know you're still around. So regarding the tutorial questions, do you find the answer from the lecture notes, the internet, or any resources you can? Have you got all the answer? So I hope these tutorial sessions would be interactive. It's not me talking alone. I hope someone can give me answer. Then we discuss it together. So who want to give you a go for these first questions? So what is the name of this appliance? Then what's it used for? We have a person text me just now, Jared. Do I pronounce the name correctly?
Yes.
Okay, Jared. Can you give it a go, this one?
This one is Frankel regulator.
Yeah, Frankel regulator. What's it used for?
Remove muscle forces in labial and buccal area that restrict skeletal growth.
Yeah, good. So this one, hopefully, this one is Frankel regulator. Of course, we discussed before, the Frankel regulator can use for the class 2 and the class 3 malocclusion. So what do you think this is used for the class 2 or class 3 malocclusions? Yeah?
Both. Both.
Both? No. You see the design? You have this one, what's it called, this one?
Not sure.
It's a lip bumper.
Lip bumper.
Yeah, what's the lip bumper used for? You see, the design is very simple. So like you say, they take away the muscle. So because Frankel believes it's the muscle or the soft tissue is causing the malocclusion. So where's the soft tissue? Labially, we have this buccinator, then orbicularis, then or whatever soft tissue at the buccal surface. Then lingually, we have the tongue, which will come to action. So we have to get away these two components, one from the labia, one from the lingual. So you see this is what we call the lip bumper. So mainly is to prevent the lip come into the actions. So this one, the lip is causing what? The lip. They're causing the lower incisor going backward, or they're causing the mandible going backward. So this lip bumper will push the lip away from the teeth, then hopefully the jaw will grow in a better position. So what do you think? With the lip bumper on the lower, they are dealing with the class 2 or the class 3? 50-50.
Class 2.
Yeah, why class 2?
Because the mandible.
Yeah, because the mandible is deficient or the mandible is shorter. So they believe maybe the lip is too strong until we can pull the mandible or restrict the growth of the mandible. So this lip bumper mainly deal with the lower lip, which is a strong muscle. So I think this one is a Frankel regulator, you're right. And these are mainly to deal with the class 2 malocclusions or the class 2 skeletal discrepancy. So we can use for division 1, division 2, doesn't matter, but mainly they are used for class 2. So this one we call it class 2 Frankel regulator. Okay, any questions for the first questions for the tutorial? No questions? Okay. Yeah.
No question, doctor.
No questions. So we go for number 2. This one I think is very simple. This one also the Frankel regulator. But look at the design. So like I explained before, this one is a lip bumper. So look at the lip bumper, you know this one is designed for class 2 or class 3. Okay, we go for Jared again. So Jared seems to answer the first question. So this lip bumper is designed to get the lips away from the teeth or the skeletal. So this one mainly to deal with the upper lips. So you think it's a class 2 or skeletal class 3 malocclusions mainly.
Class 3.
Yeah, class 3, because you see the upper lip is so strong until you can restrict the maxilla growth. So this one lip bumper, hopefully they will pull the lips away from the maxilla, then hopefully the maxilla can grow in the better direction. So the Frankel regulator, they can deal with the class 2 or class 3 malocclusion, depends the design. Okay, no questions. Then we go for this number 3. So maybe we choose a different person. Let me see. Who can I find? All right. Okay, we have Fatin Nadira.
Yes, doctor.
Yeah, Fatin, what do you think about this? Give me the name. Yeah, very simple. These are 2 blocks, one for the upper and one for the lower. They call it twin block. What's it used for?
To guide mandible forward and downward.
Yeah, the guide mandible forward and downward. Then hopefully you can grow the mandible and modify the growth of the mandible. So what's it used for? This one, which malocclusion?
Class 2.
Class 2, very good. It's class 2 skeletal pattern. Then you use it for class 2 division 1 or class 2 division 2?
Division 1.
Yeah, division 1 mainly. You're dealing with the overjet. So overjet is very good if you're using this twin block appliance. Because you see when you move the lower jaw forward, and the maxilla and mandible, the incisor will come together a bit closer. So let's say you have a class 2 division 2, which have a limited overjet, then this appliance won't be suitable. So usually for the class 2 division 1, then this one can be done. But for class 2 division 2, a lot of time we have to convert. I mean, we have to straighten the upper T, convert it to class division 1, then before we move on to the twin block. So this twin block, this twin block can be done for the class 2 division 2, but you need to fix the upper crowding first. I mean, you need to pocline the upper incisor, then before they move on to the twin block. Okay, questions. So we have number 4. So we have a lucky winner. Maybe we go to Hurin. Then correct pronouncing Hurin. Yeah? No. Lock in. But no, participating. Hurin?
Doctor, can you show me the slide?
Okay. Yeah, this one. What's it called? This one is from the lecture notes. Very simple.
It's the bionator, doctor?
Yeah, very good. Bionator. What's it used for? Simple. All the functional plans, they only deal with the skeletal discrepancy. So you just give me class 2 or class 3, 50-50. Which one is useful?
Is it for class 2?
Why class 2? You see the design for this bionatal, they have a big combination of both. You have the appliance which attached to the T. Then we have this buccal shield, which will push away all the muscle from the buccal. And palatally, you have the tongue, this palatal arch, which push the tongue away. So this is what we call the bionatal. The advantage of bionatal, you can wear it longer hours. So this bionatal have this lower incisor capping. So when you move the incisor, then the incisor will come to this area. So this one can use for the class 2 or even class 3. So because mainly they lock the jaw in certain position, then they push the muscle away, and hopefully the jaw will grow in the better positions. So this one can be used for class 2 and class 3 also. But mainly we use it for class 2. Class 2. Okay, so we have these plans. I think this one's similar, Similar. It's okay. Let's keep this. We go for number 5. So what's this called? This one interesting. This one is not in the lecture notes. So we go for maybe multi-races. We go for a different person. We have common. Yeah, common. Yeah, is coming around. No coming. Then we go for Ganjai. Is Miss Gan around? No. Can we have an In Kai En?
It's doctor.
Yeah, can you tell me what's this?
Oral screen.
Huh?
Oral screen.
Or a screen. What's it used for?
To correct some suckling habit.
Yeah, good. Where you get the answer from?
Google.
Google. Yeah, this one I call it vestibular screen. And usually mainly to break the habit. Then when the patient have this tongue sucking or even tongue thrusting, then you can use this appliance. But this appliance mainly is to train the lips. So let's say I have a flaccid or the hypertonic lips, and which is quite soft and they are flexible. So they usually have the bimax populations. So because the lip is not too soft, they are flaccid, then the tongue pressure is too big, then the tongue will push everything forward. So sometimes you end up spacing the bimax proclinations. So this mainly to train the tongue, the lips, and all the muscle. So this one, when we put into the mouth, then this one is vestibular shield. Then we go on the labial surface. Then patient will use this handle to pull the appliance forward. But the lips have to be strong enough to hold this appliance in place. So this one slowly will train the strength of the lips. Then the lip muscle will be stronger. Then hopefully there will enough to balance the muscle force from the tongue. Then at the same time, when this appliance is in place, then usually patient cannot suck the tongue anymore. So it can act as a habit breaker, or at the same time can train the lips muscle. Okay, good. Okay, we come to this number 6, which we discussed initially. So this one is the lip bumper. So what's the lip bumper used for? So we have this. There's not many people. We have this is BDDS 17091017. What is that? Can be a BDDS. Not around. Can we have I'm bacilla? Yeah.
Yes, doctor.
Yeah. What do you think about this lip bumper? What's it used for? Yeah.
For lip sucking patient.
Lip sucking patients. Yeah. Good. Good. What else?
Or any hyperactive
Yeah.
mentalist muscle.
Yeah, usually it's the muscle. Huh? You see, like just now we say the lip muscle might be strong enough. They even will push the mandible backward, or even they will push the lower teeth retrocline, or push the lower teeth backward, leaning backward. So this lip bumper mainly is just to push the lip away, and you can act as a habit breaker also. It's your lip sucking habit, but the main purpose is just to get the lip away from the teeth. Then hopefully the mandible will grow and the teeth will be straighter also. Okay, sometimes this one lip bumper, they can add as a molar distalizer. So if the lip is very strong, so let's say you attach something to the molar with a molar bends with a buccal tip, then if the muscle is very strong from the front, then the lip will push this lip bumper back, and hopefully you can distalize the molar also. So lip bumper, the second function is to distalize the molar. So this lip is very strong. Then we have acrylics at the front. So whenever the lips apply the pressure on this bar or the lip bumper acrylic, then they will apply the force indirectly to the molar also. Then hopefully you will distalize or push the molar backward. Okay, can you understand? Okay, since we are running a bit late, I think I will go through the questions and answer myself. So this one is Franco, so it's not Franco. This one is Herbs appliance. So this one is a fixed functional appliance. Fixed functional appliance. All the designs similar. We have an upper and lower component. And have a rod or the bar or the piston attached from the upper to the lower. So every time the patient bite together, then the piston will push the lower jaw or lock the lower jaw forward. So this one hopefully you can get some mandibular growth. At the same time, can push the maxilla backward, then mandibular forward, and upper teeth retrocline, then lower teeth will procline, or the upper teeth will move backward, then lower teeth will move forward. Then hopefully you can reduce the overjet. At the same time, you can get some skeletal growth. Okay, number 8. What is this? So this one is a myobrace. Myobrace is something new in the market. So I think this one won't cover in your lectures, but this one is the latest myofunctional plans in the market for the past 20 years. So this one is very famous now. You can see a lot of general practitioners, even the orthopedists are using it. So the same purpose. So this myobrace, they have a different series. Then they have teenagers, sorry, they have junior, then they have kids, then they have teenagers, they have adult. There are different series of myo brace. Because this one is just a different size. So when you come to different stage of life, then the jaw will grow a bit bigger. That's why they keep changing it. So this is just a tray. Then we have a groove on the upper, which accommodate your upper jaw. Then we have a groove on the lower, which accommodate the lower jaw. So whenever patient bite together, they'll force the teeth into this groove. Then hopefully they can straighten the teeth slowly. So I have different strength. They have the K1, K2, K3, for example. Then K1 is a bit more flexible. They open by silicone. Then maybe we move to K2, which is the next step. Then we have something stronger, which is the silicone plus the framework or the skeletal inside. So slowly they will straighten the teeth. At the same time, they position the lower jaw forward or backward. So you can use for the class 2 and class 3. Then the most important for this myo brace, they act as a trainer. Then they say they can train the tongue position and the swallowing pattern, and at the same time the nose breathing also. So you breathe through your nose, then usually they're more healthy, then the jaw can develop better rather than using the mouth. So these ones have many functions. They can act as a habit breaker, trainer, and an aligner also. So this is something new, but I think you should know because now it's a highly popular and there are high demand in the private market. So I think with that, I finished all my tutorial questions. Do you have any question to ask me before I move to this examination and diagnosis?
No question, doctor.
Good, good, good. So now I think I want to go through some ENT just because you're coming to the clinic very soon, very soon. So I think most of you already finished wire banding. Now they're fabricating the appliance. I think try to finish by maybe this one, then maybe next month you're going to the clinic. So ENT is something you need to know in detail. I think you have to go through the ENT lectures. I just go through it briefly. I'll go to. All right. So the ENT mainly to screen the patients, to identify the condition that might need the further assessment or treatment. Maybe you want to refer the orthodontist or you want to do it yourself, doesn't matter. But this ENT mainly to screen the patients whether they need the orthodontic treatment or not. Or sometimes you discover something else like pathology which might refer to oral surgery or other discipline. So if sometimes we recommend 7 years old, sometimes recommend 10 years old, depend which school you're taught. Some American, they recommend you start from 7 years, then you should screen the patients. And the British, they are a bit more conservative, they say you start from 10 years old. There's some reason behind it. So 7 years old, which is American, they say when the incisor, the first incisor, permanent incisor come out, then you should start checking the patient regularly from time to time, maybe every 6 months to a year. You should check the patients, whether they have crossbite, they're causing the lower incisor mobility or gum recession. Then maybe you have to start something early, which is called interceptive orthodontic. Do you have this topic before? Interceptive orthodontic? Yes? No? Interceptive orthodontic? This topic? Am I still online?
Yes, doctor.
Okay. You have this topic before? Interceptive orthodontic?
Yes.
Okay. So interceptive orthodontic is you have to do something early, even though they're in the mixed condition. Then hopefully you do something early and you avoid the need for the fixed appliance later, or you make the job easier in the future. So this orthodontist and American, they think you should start early when you notice something is not right. You can do functional, regulator, then hopefully you can modify the jaw also. So you should start 7 years old. But the British, they always recommend 10 years old, which is a mixed condition, mostly when the premolar start coming on. So if there's a time you catch up the growth spurt, then you can start the functional plans. If you start too early, which is not the growth spurt, then maybe you have to drag the patient for a long time. If you start right before the growth spurt, then maybe patients just have to wear the functional plans for 1 to 2 years. So imagine if it's not 7 years, then maybe the patient have to drag another 5 years before they get the fixed appliance. So there's so many reasons behind the American and the British. So I think this one I'll leave it to you. But as a British trained orthodontist, then maybe I recommend you start from 10 years old. Unless they are necessary, they have incisor, crossbite, then maybe you can start early. Other than that, I see no reason to start the braces too early because they burn the compliance. So what's the benefit of screening? Then usually you identify the developing malocclusion, whether they're crowding, spacing, the problem of the jaw, too long, too short. What's the soft tissue problem? Then it can be the upper lips or the lower lips, or lower lip trapping, or the upper lips too short. Can be habit, tongue sucking, then nail biting, so many habits. But most important, you have to identify the pathology. Let's say you have the cyst, abscess, caries, then oral hygiene, peritonitis is considered pathology. They're more important than your orthodontic treatment. So this one usually I prefer early so that we can address the problem earlier. So you can allow interceptive treatment, which I think is quite important. I say you start early, you do something early, then maybe you can make your treatment easier or simplified. Then allow patient educations. When the patient is too young, then usually cannot brush very well. then you can advise them from diet, brushing, and forcing habit. So the most important is if you need to do something which is not under your capability, then you can refer to other specialists, periodontists, pathologists, whatever, the orthodontist also. So simple examination diagnosis. So for the undergrad, we don't expect you to very detailed, but you have to know what's the basic. So extraordinary assessment, then mainly we deal with the assessment of skeletal. Okay, it can be anterior, posterior, then vertical, and the frontal. So we assess the head or the face in the 3D dimensions. So anterior, posterior, we can assess the patient whether that's class 1 skeletal pattern, or class 2, or even class 3 skeletal pattern. Then vertical, we have the high angle, which is a vertical dimension increase, then normal face, or the low, which is short face. Then frontal, mainly we assess the symmetrical of the face. You just see the left side and the right side, whether they're balanced, symmetrical, or asymmetrical. So this picture is just summarize the skeletal pattern. So if they're straight, then they're class 1. This one straight, skeletal. Then slightly convex, then this one is the class 2. Then concave is class 3. Class 1, straight profile. Class 2, concave profile. Then we have a class 3, which is concave. So class 2 convex, class 2 convex, class 1 straight, then class 3 concave. Vertical, then usually we use this Frankfurt mandibular plane, which is from the upper lower orbital into the tragus. This line is called Frankfurt mandibular plane. So this one mandibular, this one Frankfurt. So this one, when they meet behind the occipital bone, that's considered low. Then they meet in front of this occipital bone, then consider high angle. And if they meet exactly at the occipital bone, that's considered average. That's how we assess the vertical height of the face. So remember, when this line is meet at the occipital bone, then consider average. In front, consider high angle. Then it's meet behind the occipital bone, then consider reduced facial height. Transverse, very simple. Just draw a straight line from the forehead down to the nose, and then bisect the face into two parts. Then look at the face whether they're symmetrical. So everyone will have a little bit of asymmetry, which is acceptable. But when they have too much of asymmetry, that's considered asymmetrical face. So very simple. So we first glance at the patient face. Then if you notice there's something not right, mostly they have an asymmetrical jaw. Lip assessment, then the most important, you have to assess patient have the competent lips or not. So the best time is when patient walk in, then when you start talking to patients without asking patient anything, then that's the best time you can assess the lip competency. So when you start looking at the patient, then trying to observe the lip competency, ask them to rest, then patient usually will get a bit nervous, then they will close the lips, then you can assess the lip competency. So the best time is when patient relax, when they just walk in, then you just start chit-chatting, how is your school, what's the name. That's the best time you can check the lip competency. So at vertical, then you can check the upper lips and lower lips, whether they are covering the incisor good enough. There's sometimes the upper lip too short, then patient have the incisor exposure, which is more than average. And if not careful, sometimes patient have a gummy smile. Then vertical, then the lower lips also, you can see the lower lips, sometimes they'll trap behind the upper incisor, then they'll cause the lip incompetency. So you have to check the upper lip, lower lip, and the lip competency overall. So intra-oral assessment, you can check the number, then the tooth morphology, then the position of the teeth, then the occlusions in the ICP, intercuspal positions. So it means the patient biting together. You're going to measure the overjet, then you have to measure the overbite. Is it normal, increase, or decrease? Then you have to look at the center line for the upper. I'm talking about upper and molar center line compared to the facial midline. So the center line always, when we say the center line or the upper and lower, we correlate it to the facial midline. So note the buccal segment also, whether they're class 1, class 2, and class 3, molar buccal segment, canine buccal segment, and the incisor relationship. So is there any crossbite? Crossbite can be anterior, posterior, or unilateral or bilateral. And we also look at the habits and pathology. Habit means a thumb sucking habits. Pathology is caries, then periodontitis, viral abscess, viral noctis, TMJ problem. So we know the elapsing sequence, how the teeth come out. For the maxilla is first molar, then followed by the incisor, central incisor, lateral incisor, then first premolar, second premolar, then followed by the canine, which is the last one to come out. And 7, 8, of course, second molar, then third molar is the last one. But third molar is not what we concern for braces. Usually third molar exclude from the diagnosis. Then we mainly look at the 1 to 7. So if you look at the upper and lower, the main difference is the canine eruptions. So the lower, the canine will come after the lateral incisor. For the upper, then the canine usually the last one to come out. So for the lower, the last one to come out is a premolar. For the upper, the last one to come out is a canine. So when you see the crowding, for the upper, mainly is on the canine regions. Very simple. The rationale is whoever comes last, they usually not enough space. So the canine will come last. That's why they're always crowded. Simple. Of course, if you can remember the age of eruptions, there will be a bonus. So supernumerary, first thing first, it's very important, you count the T number. So whenever you come for the exam or whenever ask key questions, you always count the T. That's basic. If you miss a missing 2 or extra 2, you'll fail straight away. Very simple. Count the T first. Count the T whether the extra or missing 2. So this one is a supernumerary. There are 2 incisor. There's something in between. This one called supernumerary or mesodense. Hypodontia, missing T. Then this one number 2 is missing. Count the number. Always count the number. 1, 2, 3, 4, 5. Count the number. The rest missing. So impacted T, then we're talking about canine mostly. Canine mostly, and the lower lateral, lower second premolar. They are the last one to come out in the series. They will say always get impacted. Third molar, like I say, third molar is not our concern for braces. Then usually we'll exclude the third molar. The third molar, usually when they come for assessment, they are not there. They are not erupted. Even if they're erupted, mostly they're impacted. So you are not taking care of the third molar most of the time. Unless the molar missing, they want to move this third molar forward, then maybe we consider putting a braces in the third molar. But most of the time, then we ignore the third molar. So delay eruptions, when you notice something, one side erupted and the other side is not erupting more than 6 months, then you should take an X-ray. Always take an X-ray. If you notice something is not balanced, left side coming out, then right side is not, or left side come out, then right side is not, more than 6 months, then there's something not right. Then you should take an X-ray, see if anything is blocking the teeth from coming out. So for this example, there's a supernumerary stopping the central incisor from erupting. So this one, if you without an X-ray, you would know that. So these patients have been waiting for years, but the central incisor is not coming out until someone took an X-ray and found out there's a supernumerary. Once you remove this supernumerary, then the tooth will come out spontaneously. Thumb sucking habit, then usually you ask the patient about the thumb sucking habit, then they will say no, but you see there's a unilateral crossbite and unilateral open bite also, then you start suspecting patient have the thumb sucking on the right side or the left side or the middle, depends where they put the thumb. Then the next thing you should check is the thumb or the fingers. Check all the fingers. Sometimes not only the thumb, sometimes the other fingers, they're sucking. So thumb sucking habit, then usually cause some ulcer or some scarring to the thumb or the fingers. Sometimes even it's not the fingers, they are biting the pens or pencil. This one cause an open bite also. So overjet, very simple. You just measure from the front surface or labial surface to the labial surface. So for the upper to the lower. Labial surface or upper incisor to labial surface lower incisor. That's how they measure the overjet. The ruler must be parallel to the occlusal plane. So you measure the overjet, You don't tilt the roller up and down. Must be parallel to the occlusal plane. So from the incisor to incisor, labial surface to labial surface. That's how you measure the overjet. Of course, reverse overjet the same. From labial surface to the labial surface. Reverse overjet positive, negative is the same. Must be parallel to the occlusal plane. Recent decidus, this one pay very careful attention to this because sometimes this one can sink. We call it submerged decidus. So you leave it long enough without doing anything, this one can submerge totally until it disappear from the visions. So sometimes this one submerge until the other teeth will come into the space, then this one will disappear. Until someone take an X-ray, only they notice that the decidus is still buried inside the bone. So what happens if this decidus, sometimes we get ankylosed, it means they fuse with the surrounding structures. Then the bone will continue to develop. It means the upper and lower teeth will continue to become longer. Then the teeth will left behind. So you have to do something early because if you didn't take out this submerged decidus, the decidus, the permanent adult teeth cannot come out. So this one will cause the obstruction or blockage to the eruption of permanent teeth. Then if you do something early, which maybe you don't need the surgery, if you do later when they submerged too much, then you have to go for minor oral surgery. So anterior open bite, same thing, you measure from the incisor edge to the incisor edge. Incisor edge to the incisor edge. So this one you measure the worst one. Okay, so many open bite here, then you should measure the worst, which is from lateral incisor, in this case, to the canine. So anterior open bite, measure the worst one. Like this one may be 3 millimeters, then this one may be 5 millimeters. So we take the 5 millimeters open bite. Cross bite with the gum recession, this one I have to pay attention. Whenever I come to cross bite, always check whether this cross bite causing the trauma or the initial contact to other teeth, which is causing the heavy force to a certain particular tooth. It causes mobility, meaning the teeth are mobile, and at the same time it causes gum recession. So you notice the gum recession, then maybe there's a heavy force to this particular tooth. You see what happens to the cross bite? Every time patient bite, then keep pushing this lower incisor forward. Then this one with heavy force, they cause a gum recession and mobility. And when we come to this cross bite, then you have to do something fast before the teeth will be further compromised. So this one you have to intercept early so that these two can be safe. Anterior posterior cross bite. So this one very simple. Wherever the bite is reverse or negative, then this one considered cross bite. So whether this cross bite is anterior or posterior or bilateral or unilateral, you have to note it down. Morphology, then you can look at the teeth, shape, the size, then you will notice the abnormality. For this one, it's dilacerated, means the teeth is pointing upward. There's a change in the crowned angulation, so we call it dilacerations. So mainly it's due to the trauma when they're young. So this crown will push up. So when they erupt, they're coming out from the buccal surface rather than coming out from the occlusal surface. So on the right side, this one is a peg-shaped lateral incisor, and the missing lateral incisor on the other side. So when you see the peg-shaped lateral incisor, then sometimes you should have the missing lateral incisor on the other side. This one I have to note down, the size discrepancy. Frenum, so mainly you check the frenum. You're trying to pull the frenum away from the teeth, and you just say this is causing branching, or they have a strong muscle insert between these two central incisor. Mostly they're causing the median diastema or the spacing. So this kind of patients, a lot of time we have to refer for the frenectomy. It means to cut the frenum away, reposition it to the higher position, then hopefully this muscle won't come into the space between the central incisor. So later you can close this space with the braces. Okay, I think I cover the simple diagnosis. Do you have any question to ask me? No questions? With no questions, I think we will end this tutorial.
No question.